Hello everyone, welcome to your webinar series dedicated to bringing discoveries to patients this year. Really appreciate your participation. My name is Meena Lakshman. I'm the Applications Marketing Manager here at FUJIFILM VisualSonics, and I'll be moderating this webinar. Today's webinar is titled Kidney and its Pathologies, with a focus on ultrasound imaging of the kidney and lower urinary tract in development and disease. We will begin with some housekeeping announcements. A recording of the webinar will be made available to you. All lines will be muted for the duration of the webinar, and please use the chat window that you'll find at the right of your WebEx screen for questions. We will answer all questions at the end. We will also prompt you to deploy your questions in the chat window. The expected duration of this presentation is 45 minutes with 10 to 15 minutes towards the end for questions, and we'll have a stay connected segment to innovation. You'll also find upcoming webinars at VisualSonics.com webinars. We'll now move on to introduce our speaker. We are really honored to have Dr. Carlton Bates speaking on his research expertise using ultrasound imaging and his findings and advancements to his research program. His research is primarily focused on the role of fibroblast growth factor receptors and their adaptive binding proteins, particularly in kidney and lower urinary tract development using mouse models. He comes to us from the University of Pittsburgh, where he's a professor at the Department of Pediatrics. He has an extensive track record of publications and funding on the topic of fibroblast growth factor receptors, particularly in genetic models, conditional and global knockout models. These approaches have revealed many novel roles for the receptors, and he has mouse lines that often mimic many of the congenital forms of kidney and bladder disease that are leading causes of renal disease in children, and his presentation falls right into the spectrum of today's theme, this webinar's theme, bringing discoveries to patients. So Dr. Bates, we will now transfer the presentation rights to you, and the floor is all yours.
Thank you, Meena. Thanks for that kind introduction. Yes, my name is Carl Bates. I am the Division Chief of Pediatric Nephrology at Children's Hospital of Pittsburgh of UPMC. And so we're going to review a little bit about some of the ultrasound imaging that we've done in the kidney and lower urinary tract in both development and disease. So the primary objectives for today are first to describe the use of ultrasound with microbubble contrast imaging to detect vesicoureteral reflux in live mice. And some of this is based on some published material that we have, as well as some unpublished data. The second objective is to look at ultrasound imaging in progressive bladder distension and hydronephrosis, or swelling of the kidney, in mice that have a deletion of FGF receptor 2 in bladder mesenchyme. And this is all unpublished data. And then the last part of the talk will be to give an overview of our upcoming 13th International Workshop on Developmental Nephrology, which will take place July of 2015. So first, to look at ultrasound with microbubble contrast imaging to detect reflux in live mice. The first point is that vesicoureteral reflux, which is backflow of urine from the bladder to the kidneys, affects about 1% to 2% of the population. Most children, fortunately, have resolution of their reflux with age and don't go on to develop any significant problems. A subset, however, develop what's called reflux nephropathy, characterized by scarring and inflammation of the kidney, and unfortunately is the fourth leading cause of end-stage kidney disease in children. Many of the risks for developing reflux nephropathy are unclear. We don't know why some patients develop it and others do not. Therefore, we and other laboratories have been examining mouse models of reflux. So the state of the art for detecting reflux in mice has been historically to inject dye into the bladders of euthanized animals. And in this image, what you'll see at the bottom part of your screen, there'll be a bladder that's being filled with blue dye, and then you notice with the arrows, the dye fills the ureters and backflows up toward the kidneys, which are at the top of the screen. So while this is a nice imaging method, there are problems with this. First of all, you can't perform serial imaging in these animals because you have to euthanize them in order to do the assay. The other is that you lose the live physiology of the tissue. These are euthanized tissues, and normally the ureters will propel urine down from the kidney toward the bladder, countering the effect of the reflux. So because of these problems, we generated a live ultrasound microbubble contrast assay, and we did this based on published data in humans. So the first point is we had to use female mice for this assay because we had to introduce a transurethral catheter, and that really can't be done effectively in males. The urethra is too long. So we used females, and we used 2 different inbred strains that had known rates of reflux based on the euthanized cystogram method that you saw earlier. So C3H HEJ mice are known to have 100% rates of reflux using the euthanized cystogram method, whereas C57 black 6 mice have no evidence of reflux at all. So we applied isoflurane anesthesia to these mice through a nose cone on a warm surface. We removed fur with hair removal lotion to do the ultrasound imaging. We then advanced PE10 tubing through the urethral orifice into the bladders of these mice. We then imaged both the kidneys and the bladders with a Vivo 770 ultrasound machine in the fundamental or the bright mode, and this is just to see where the kidneys and the bladders were, that we could image them correctly. We then injected the contrast microbubble agent diluted in PBS directly through the catheters into the bladders at 50 microliter boluses per minute, up to a total of 250 microliters. We then imaged the bladders to show that the bubbles were present, and then any refluxing bubbles up into the kidneys, and this was done in the subharmonic or the dark mode. So this is just a schematic, just a picture of what we were doing with one of our mice. So the mice, this is a mouse that's lying prone on a warm surface. You can see the nose cone through which there is the isoflurane anesthesia. There is a picture of, this is the catheter which winds around and is going through the urethra into the animal. This is the dorsal surface of the animal in which the ultrasound probe is applied. And you can see that the screen back here is imaging the kidney. So this is in the bright mode, the fundamental mode, and the lighter colored area, that's the tissue, that's the meat of the kidney. And then the dark area, as seen here, is the urine that's accumulating within the renal pelvis. So these are just some still images of the live cystograms that we did, and then we're going to follow those up with some movies so you can see this, what this looks like. So here are the C3H mice on the top row. These are the mice that have the high rates of reflux. The C57 mice have no reflux. And the first image is simply to look in the fundamental mode at the kidneys. And so you can see around here, this is an image of the kidney. And again, most of this is the meat of the kidney, and the renal pelvis is the dark area here. That's where the urine accumulates before it hits the ureter. And it's the area we're going to look at for signs of reflux, if it exists. Here's a C57 black 6 mouse. Again, this is the kidney, and the dark areas would represent the renal pelvis. So the next images are in the subharmonic mode, looking at pseudo-colored bubbles. And this is looking at the kidney itself. And what you'll see here with these pseudo-colored bubbles, this represents bubbles that have refluxed up into the renal pelvis of the C3H mice. This is an overlay of the fundamental mode, so you can see the outline of the kidney, and the subharmonic mode showing the pseudo-colored bubbles that have tracked up into the renal pelvis of the C3H mouse. In the C57 mice, you'll notice that there are no bubbles present, in the renal pelvis of the kidney, and this is as expected. And this is another overlay image where you can see the outline of the kidney and no bubbles present within the pelvis of that kidney. The final panels are simply to show that there are bubbles present within the bladders of each of the mice. So you can see the pseudo-colored green bubbles are present within the bladder of the C3H mouse on the upper panel, and similarly, there are bubbles present in the bladder in the C57 mice. So the fact that there's no reflux in the C57 mice, we're showing that there were truly bubbles present in the bladder and there really was no reflux. So now we're going to look at a series of movies, and this is a C3H mouse in the subharmonic mode looking at the bladder, and what you see here are the bubbles that are being injected into the bladder, and this just shows that our catheter is in the right position and that indeed there are bubbles present within the bladders of these mice. The movies for the C57 mice look similar, so we don't show a movie for that one. So then moving to the next slide, this is a C57 mouse. Now we're imaging the kidney in subharmonic mode, looking to see if there are any bubbles present or making their way refluxing into the renal pelvis, and essentially there's nothing. So you can see there's just black. There are no white-colored contrast bubbles making their way up into the renal pelvis of either kidney within the C57 mouse. As we advance to the next slide, we'll see that this is a C3H mouse, and where the arrows are pointing is where you'll see flashes of bubbles that are making their way up into the renal pelvis of both the right and the left kidneys. So you can see that there is, what this means is that there's almost a continuous reflux going on. There's bubbles refluxing up and back down and refluxing up and back down. So there are high rates of reflux almost on a continuous basis in this animal. So moving to the next slide, this is just to show the C3H mouse back in the fundamental mode. And what we're seeing then is you can actually see the kidney itself. Now you can't see the bubbles here, but where the arrow is pointing is in the renal pelvis where the bubbles are refluxing up. You can see the fluidic movement there in the dark parts. That's the urine. That's what's receiving the bubbles that are moving back. You can't actually see the bubbles, but you can see the movement of fluid. This is showing almost the pulsatile reflux that's going on within the C3H mouse. So as we move to the next slide, now we can do what's called maximum intensity projection. Basically what this shows you is the accumulation of the bubbles within the renal pelvis of the C3H mouse. So anytime any bubble makes its way up there, that image is fixed there and we see the additive accumulation of additional bubbles. So the advantage to doing this is you can actually, after a while, begin to see the three-dimensional view of the renal pelvis and even of the ureter, if you do this long enough, where the bubbles are contrasting up, or refluxing up into the kidney. So moving to the next slide. So this is a still image in which we have done 3D reconstructions of the right and the left kidneys using the MIP mode to see the accumulation of the bubbles. So you can see on this side, so first in the middle, there's the spinal column, just showing you, the midline of the mouse, and the two kidneys on either side. The one on this side where you're looking at the renal pelvis with the bubbles that have accumulated there, as well as the ureter. And similarly on the other side, the ureter and the renal pelvis. That's for the C3H mouse, which has reflux. The C57 mouse, of course, we didn't see any reflux, so all we can see here is the spinal column and an absence of any bubbles or contrast in either of the two kidneys. So taking this a step farther, you can actually take these 3D reconstructed images and then calculate different axes, the wide axis, the long axis. As we rotate this a little bit, the depth axis, we can trace around these layers, these different stacks, and from that generate a volume. We can also, from these images, generate a surface area. So you can actually quantitate to some degree the reflux in terms of the volume of contrast that's made its way up into the renal pelvis of the animals. So the summary of the live cystograms are that it has many advantages over doing euthanized cystograms. One is that you can do repeated measures of reflux in the same mouse over time. So if you expect that as in humans, reflux would tend to get better with age, you can take the same animals and see if over time the reflux improves. It's clearly a more physiologic assay than doing euthanized cystograms. They're live tissues. We have again, the propulsive movement of the ureters to counteract the reflux. So it's a much better physiologic system. As I mentioned, you can calculate the degree of pelvic dilatation as an actual quantitative measure of the reflux. Now, there are some disadvantages over euthanized cystograms. One is that you can only place the transurethral catheters in females, as I noted previously. Now, to overcome that in males, you could actually percutaneously place catheters into the bladders of males, but then you wouldn't be able to do repeated measures in the same animal as you could with the females. The other major issue is that it does take a bit longer to perform. It takes about 30 minutes to do a live cystogram as opposed to 5 minutes for euthanized cystogram. So now we're going to move to the second objective of the talk, which is to describe the use of ultrasound imaging of bladder distension and hydronephrosis, which is swelling within the kidney. These are in mice in which we have deleted fibroblast growth factor receptor 2 in bladder mesenchyme. So to give you some background, the reason we're interested in looking at bladder models is that up to 35% of children that have end-stage kidney failure have associated lower urinary tract disease. This could be in the form of a structural obstruction, as in the case of posterior urethral valves, or a functional obstruction, an example being non-neurogenic bladder. These are kids that basically hold their urine to the point that they have backflow to the kidney and damage. Beyond children, adult diabetics and elderly males are at high risk of developing atonic bladders. These are bladders that don't contract very well, where there's accumulation of urine and potentially back pressure into the kidneys. Poorly functioning bladders can also lead to risks of many things, including kidney stones, urinary tract infections, and kidney damage in patients of any age. In virtually all cases, there have been no identified genetic determinants for structural or functional bladder defects. So there's a lot of bad bladder disease out there, and no one has identified genes that may be mutated that are driving the pathology. So we generated a mouse line in which have both embryonic and postnatal bladder defects, including less muscle in the bladder and more lamina propria, submucosal lamina propria. Volume and area is expanded. The mice also have problems with high rates of reflux, like we described in the earlier model, and defective ureteral peristalsis. This means the ureters that normally have peristaltic movements to drive urine toward the bladder, those peristaltic contractions are defective. At least in terms of the bladder mesenchyme defects, it appears that FGF receptor normally acts to repress hedgehog signaling in bladder mesenchyme to properly pattern the muscle and lamina propria, and that in the absence of FGF receptor 2, you have excessive and inappropriate hedgehog signaling that leads to a shrinkage of the muscle and an expansion of the lamina propria. Early postnatal mice have very poorly compliant or stiff and fibrotic bladders that also do not contract well, related to a loss of muscle. As these mice age beyond 3 months of age, they flip from having a stiff, poorly compliant bladder to a floppy, overly compliant bladder. These bladders become virtually atonic, as similar to the subset of diabetics in older males, as I've mentioned previously. The bladder defects, combined with the previously mentioned high rates of reflux and poorly functioning ureters, leads to progressive hydronephrosis or swelling in the kidney and chronic kidney disease. So these are just some of the results of, and this is from our published data. If we look at the histology of some of the newborn mouse bladders, you can see in the controls, this is a low power H&E image, where you get a nice outer muscle layer. That's what's here in the dark pink. And then the submucosal lamina propria, which is mostly white colored. And then on the very inner surface of the lumen in the bladder is the urothelium. And if you do look at a close-up by trichrome staining, that there's robust muscle present here. And there's no fibrosis. There's no blue collagen staining here or fibrosis that's present. Now, the mutant doesn't look too bad. It forms a nice outer muscle ring here. But if you look on trichrome staining, you start to get the sense that the muscle's carved up a little bit, and then there's some blue staining, which is represents collagen trichrome staining on trichrome. When we look at a 3D reconstruction of these bladders, we see that compared to controls, which are in the black bar, the white bars, which represent the mutants, have less muscle by total volume, and an expansion of the lamina propria, and no change in the urothelium. By 1 month of age, the histological defects become very apparent in the mutants. So we see on H&E staining at low power, a bladder that's present here, with, again, a control with a nice thick outer layer of muscle. If we look at a higher power image, the muscle's very thick and robust, and beneath it's the lamina propria. And on trichrome staining, you can see a little bit of blue collagen fibrils present within the muscle, as is appropriate. You can see that the mutant looks markedly different. The muscle is clearly thinner, and if you look at a closer view of that, you can see that it seems to be carved up and separated, not only thinner, but it's separated. And if you look at what's separating it on trichrome stain, you can see the blue collagen fibrils that are separating the muscle fascicles. By 3 and 6 months of age, the mutant phenotypes become much more severe. So 3-month controls have nice, robust bladder muscle, similarly at 6 months. The mutants, however, have very, very attenuated thin muscle and very, very overly distended bladders. The same is true at 6 months. So how is it that we've used ultrasonography to help interrogate the phenotypes of these mice? Well, the first way that we use this is to look at the bladders. So this is doing ultrasonography at 3 and 6 months of a control bladder. And what you can see here is the dark, again, represents fluid or urine. So this is a normal bladder size for a 3-month-old control mouse. And you can see, as you might expect, as the mouse ages and gets bigger, the bladder size does increase a bit with age. If we look at our mutants, however, the bladders are much larger and much more distended, both at 3 months and at 6 months, compared to their littermate controls. And to give you a tissue correlate for these changes, if we look by gross dissection at 3-month and 6-month-old controls, the bladder is very tiny, as expected. Normally, this would hold about 1/2 ml of urine at most. And the bladder is very compressed here, decompressed, in a 6-month-old. They're very small bladders. You can see in the mutants, the bladders are much larger and more distended. This would probably hold 5 or 6 mLs of urine in this 3-month-old, and look again at the bladder in the 6-month-old. So again, the advantage here is we can image these mice consecutively and look at the changes in bladder size over time without having to euthanize the mice at these earlier time points. So what's the effect on the kidney? So again, we can use ultrasound to help us determine the effects on the kidney architecture. So this is a histologic section of a control 1-month-old kidney. You can see the outer cortex, the inner medulla, the renal papilla, and then the surrounding area around the papilla. This would be the renal pelvis, where the urine is accumulating as it heads out the ureter. We do an ultrasound image in a live animal. You can see this is the outer cortex of the kidney, the meat of the kidney, which is the brighter color. And then the dark would represent the renal pelvis, where the urine is collecting. But there's very little there, as expected. Well, in our 1-month mutants, we see some variability, ranging from mild hydronephrosis, that is a little bit of expansion of the urine accumulating within the renal pelvis and some compression of the renal papilla, to massively distended renal pelvis with compression of the papilla. We can look at ultrasound images and see those same correlates in live mice. So this would be the kidney itself, and the dark would represent the mildly distended renal pelvis in this mouse, whereas this one, as you can see, has much more distension, similar to this image on the histological section, with a very compressed papilla. By 3 and 6 months of age, the phenotype becomes more severe. So here we have a control again. This is a normal control kidney. This little rim of dark would represent the renal pelvis, which would be similar to this histological section down here. All of our mutants at this stage have hydronephrosis of variable severity. You can see in this one, there's the kidney. You can see the renal papilla is a little bit compressed, and there's some dark urine accumulated, certainly greater than what you see in the control. And this is the histologic correlate, where you see some expansion of this renal pelvis and some compression of the papilla. Now compare that to this mutant that is severely affected, where the kidney, you can see, is very widely splayed open here, a very compressed renal papilla, a very expanded renal pelvis, similar to this histological correlate. So again, we can track the same animal from really essentially birth all the way through 6 months of age to look at the relative changes in hydronephrosis over time, sparing us animals. So to re-summarize this, the summary of how we've used ultrasound to assist in our bladder mesenchyme knockout mouse studies, it allows us to perform non-invasive serial imaging of both the bladders and the kidneys. It saves us from having to sacrifice animals at each time point of interest. So we can do the ultrasound imaging at these earlier time points. We can obtain blood and urine specimens from these intermediate time points of interest as well. So that's the conclusion of the discussion about the use of ultrasound in our studies. And I wanted to turn my attention a little bit to the upcoming 13th International Workshop on Developmental Nephrology, which is being held in Snowbird, Utah this July, from the 12th to the 16th. So an overview of the developmental workshop, it features cutting-edge developments in cell fate, differentiation, and morphogenesis as it relates to normal and abnormal kidney and lower urinary tract development. It brings together a wide array of people, including clinician scientists such as myself, pediatric nephrologists, adult nephrologists, and urologists are some examples, along with basic scientists who study developmental biology, kidney regeneration and repair, stem cells, and congenital kidney and urinary tract, lower urinary tract disease. It's a really nice meeting. There were about 100 to 150 people that show up. It's similar to a Gordon conference. There are lots of abilities for people to communicate, to set up collaborations. Just to mention some of our current sponsors and people that are endorsing us. The International Pediatric Nephrology Association helps sponsor the meeting. This next line represents people that are endorsing the meeting. The top line here, this middle line I should say, includes different pediatric nephrology groups across the world. And then the lower line, I have other nephrology groups, the International Society of Nephrology, and the American Society of Nephrology that also endorsed the meeting. This is the current organizing committee. I'm the chair of the organizing committee. My co-chair is Greg Dressler. And you can see we have an astute panel of organizing committee members from across the world, all of whom have an interest and a research background in kidney development. And to give you an overview of the program, we have two keynote speakers, including Mario Capecchi, who is a Nobel laureate who's done some outstanding work as it relates to Cre-Lox technology, is going to be one of our keynote speakers, speaking on gene targeting and looking at mouse models of human disease. And also Dr. Cecilia Lowe from the University of Pittsburgh, who is an expert on the role of cilia and cilial defects in genetic causes of cardiovascular and kidney diseases. There'll be 6 different invited sessions featuring 37 outstanding speakers from across the world with expertise in nephrogenesis and tubulogenesis, human and translational development and disease, ureteric morphogenesis, lower urinary tract development and disease, nephron progenitors, stromal and vascular development, finally stem cells and regeneration. We also feature 2 platform sessions with 8 talks per session, and these are chosen from the submitted science, from the abstracts, tending to favor junior people to give them a chance to speak. We'll also have then 2 poster sessions, which will include the submitted science that is not chosen for an oral platform talk. In addition, the National Institute for Diabetes and Digestive and Kidney Diseases Institute of the NIH will be present, featuring a hands-on workshop for their Good Map, which is a genital urinary development and molecular anatomy project. This is a website through which people can interrogate gene expression in different parts of the kidney and lower urinary tract, and is very helpful to those of us that are doing kidney and urinary tract-based research. The venue is excellent. It's Snowbird Ski and Summer Resort, and you can see some of the images from the resort. It's 29 miles from Salt Lake International Airport, which is easily accessible from many different parts of the world. The pricing is pretty good. It's over $139 per room per night, excluding taxes and fees. You can even have a roommate with no extra charge. It's $400 for full registration, $200 if you have an accompanying guest. That'll cover everything, including the opening reception, all the sessions, and all meals throughout the course of the conference. And this is the website if you'd like to look at information and instructions on submitting abstracts and registration, etc. So I guess I'm done a little early, but just to then acknowledge people in my laboratory in particular that are in the bold green here that did the work that I presented today, and others that are highlighted in green that are collaborators that participated in helping us with those studies that I presented today. And then funding sources, including the NIH, the funding source for the conference, the International Pediatric Nephrology Association, and the March of Dimes. And with that, we'll take some questions.
Okay, Dr. Bates, that was a great presentation. Thank you very much for bringing these in vivo assays into the forefront and sharing your expertise, particularly in kidney and its pathologies and other diseases in which the kidney is affected. A couple of questions here, and I'll start with an overview question. You showed these in vivo assays in the context of CKD, hydronephrosis, but more focused on the pediatric population. So the question here is, in your expert opinion, how can these assays be perhaps modified or manipulated to diabetic models or adult or genetic models, but in the adult stage? Do you envision modification to these assays or calculations or inferences in these assays?
So if you'll notice, the images that I showed were principally in postnatal animals, including mice up to 3 or 6 months of age. So even though you're correct that I'm a pediatric nephrologist and many of the questions we're interested in tackling are related to pediatric interests in many ways, the animals we're actually doing the assays on, the earliest one that we did was 1 month of age, which already is at least adolescence. And the oldest mice were 6 months of age. So absolutely, these techniques, these same techniques can be easily used in older animals. In fact, that's where we've been using most of them. So even when we're talking about pediatric structural kidney disease, we're looking at outcomes at 3 and 6 months of age. And so yes, this could be, these techniques could absolutely be adapted to, and in fact, we already are using them in adult animals.
Okay, thank you. Along those same lines, studies that address toxicity in the kidney, so if there's a drug being developed and there are toxicity studies, do you see that your cystograms or assays with respect to the downstream to the bladder, could those be used? Perhaps can you comment on it?
Well, if you're talking about acute toxicity, I would think that it would be less likely that this type of imaging would be of much help, unless you were doing something to look at perhaps a blood flow imaging assay, something like that, which is not anything that I presented today. Certainly the chronic problems related to toxicity within the kidney, namely in the form of increased echogenicity of the kidneys that become smaller over time. So if there's some insult in which you want to track the long-term consequences to the growth and health of the kidney, these assays would clearly be useful. As I said, for acute injury models, you know, if you wanted to, I don't know that this would be as helpful. I suppose if you had acute inflammation, what you might see is actually an increase in the size of the kidney with inflammation. So you would likely be able to detect that. If you wanted to look at other things such as blood alterations in blood flow, there probably would be some techniques using Doppler flow or other things that could be used to image that. I think more likely chronic imaging would be most helpful.
Okay, that would be great. So then I think also the aspect of changes in kidney size, you showed that with 3D MIP, however, that was on the contrast on subharmonic mode, correct?
Right. I mean, in terms of reflux, I wouldn't anticipate any sort of a toxic injury would alter the risks of reflux, unless you introduced an obstruction. If you introduce obstruction to urinary flow, you might at that point introduce reflux, in which it might be useful. In fact, there could be models of, in humans that have, children that have posterior urethral valves, that is a valve leaflet in the urethra, that get obstruction, an obstructive nephropathy with backflow of urine from the bladder to the kidneys. If you have unilateral reflux, can actually be protective because you essentially blow out that one kidney and protect the other one. So our techniques would be useful if you had a model of obstructive nephropathy to look for reflux as well.
Absolutely. In one of your slides, you showed the histology of these of the kidney and the trichome stain, which shows the presence of fibrosis, if I'm not mistaken.
Yes.
So could development of fibrosis in kidney and the detection of that be facilitated using contrast-enhanced ultrasound?
Well, in fact, you may not even need to use contrast-enhanced ultrasound. And I know from my experience taking care of patients that have chronic kidney disease, if you have a lot of fibrosis and scarring in the kidney, you'll see very echo-dense and small kidneys. So I would predict that even in the absence of any contrast, you should be able to see increased echogenicity over time as as your kidneys become more fibrotic. Now, if you have patchy fibrosis, it may be difficult to use ultrasound to detect that. But again, if you do, I didn't show the data here, but we have other models where we do serial imaging of kidneys over time, as we do see progressive chronic kidney disease, and we do see that the kidneys become brighter, more echo-dense as the fibrosis occurs.
Oh, we look forward to the publication of that data. There's one last question. In your experience, what's the minimum volume with contrast bubble that is needed? Basically, the question is along the lines of what is the ultrasound sensitivity to pick up defects in the kidney architecture?
Depends on the rate of if you're doing it the way we're doing it, injecting into the bladder, really depends on whether your mouse refluxes or not, and whether they reflux under low pressure or not. In the case of the C3H mice, we would see reflux even as low as the first injection of 50 microliters of contrast. Those mice reflux under very low pressure. If you have another mouse mutant or mouse strain where it takes a bit more pressure to see reflux, you may have to increase the volume. I didn't mention that in the C57 mice where we really don't see reflux, if we go well above 250 microliters of contrast, we can force, by filling the bladder and increasing the pressure, a little bit of transient reflux, but that's when we massively over-distend the bladder. So, as I say, it depends on the mouse. In the case of the C3H, 50 microliters alone, we'd often see bubbles entering the renal pelvis.
Right, that is true. I guess that in itself answers the sensitivity of ultrasound, at least in your model. Okay, that brings us to a close to the questions section. Thank you very much, Dr. Bates. We will move on to the last segment of this webinar, updates through the Stay Connected to Innovation segment. I'd like to bring to your attention that there is a bibliography available to those of you working in urology research, and we're thankful that you were able to participate in this webinar. The publications that we have compiled for you are along the lines of genetic or spontaneous in vivo models, either in kidney disease or diseases associated with changes in the kidney architecture, also protocols for in vivo imaging methods, and calculations that allow you to infer the state of the disease and if there are any interventions that you may use, like to test drug development in the preclinical phase. It allows you to provide inferences that can be translational or help move your drug along the pipeline. Next slide provides you the next two slides will provide you some key papers that have come out very recently. Here I've selected for you a paper on kidney cancer, but more importantly to highlight how this paper has used 3D imaging to segment, and if I can show you the segmentation in blue versus red. The red is shown in panel A. The red actually segments the kidney, and the blue shows the tumor enveloping the kidney in the control panel, and with different drugs and combination of those drugs, you can see the resolution of those tumors as shown in the context of the kidney's overall size. So a great paper in terms of quantification and segmentation of diseased versus non-diseased parts of one organ. In this case, it's tumor and showing intervention studies. This was a cancer research publication last year. Next slide takes a different turn in the urology arena. It's with respect to bladder inflammation. We just heard Dr. Bates talk about bladder distension. In this case, it is inflammation due to a bacterial infection. Here they present something similar to what Dr. Bates presented to us, comparing ultrasound of the bladder and the histological counterparts. And this paper came out in 2012. Here again, I'd like to make the point that pathways of inflammation and fibrosis was the main goal of this paper, and used obviously models of this disease. Next slide. This slide actually demonstrates to you the imaging of the prostate. In this case, you see a schematic right in the center of the slide, showing the bladder right in the middle of the slide, and the prostate lobes just underlying the bladder. And onto your left panel, you see the equivalent ultrasound representation with the bladder on the top and the two prostate lobes onto your left bottom of that image. So this image was captured at 40 megahertz using the MS550B transducers. This image is a sagittal 3D view. A 2D view is presented at the very bottom middle panel to demonstrate to you that we can see the intricacies of the prostate gland in that view, with the bladder situated on the left side of this imaging panel. On the very top right, it's very nice to see that there is Doppler signals, and I'd like to turn your attention to those red signals in a 3D image. You'll see that none of the Doppler signals actually intervasate into the into the prostate gland. As you may know, that prostate is normally hypoxic. So that covers the organs predominantly in urology research. While these three slides that I've selected for you have content on the different organs in adult mice, Dr. Bates, however, complemented this data with the pediatric or the embryology stage. So we'll move on to the next slide, where I'd like to bring your attention that all this, what you've heard here today, was presented using data acquired and quantified on the Vivo imaging systems. This is the family of Vivo imaging systems as we know today. And if you'd like to know any more information, please check our website at www.visualsonics.com. If you have received our recent launch of the Vivo 3100, I'd like to remind you that it has a very different and customized look for improved workflow for high throughput. Please let us know if this is of interest to you. This brings us to the very last slide of our presentation today. I'd like to leave you with the announcement of the next webinar on April 15th. It's an on-demand tutorial on the topic of how to measure cardiac wall strength. So we'll be switching gears to cardiovascular biology. And if you'd like to share your expertise, as Dr. Bates did today and others before him, let us know. You know where to contact us, and we will be more than happy to evaluate your proposal. So on behalf of the FUJIFILM VisualSonics team and Dr. Bates for a fantastic presentation today, I bid adieu, and we look forward to your participation at the next webinar. Thank you, Dr. Bates, and thank you all. Ciao for now.